Let's review Fuchs dystrophy. Fuchs endothelial corneal dystrophy is a very common dystrophy affecting the corneal endothelium. The endothelial dysfunction leads to corneal edema, resulting in glare, halo, and reduced visual acuity. The condition progresses over decades and is characterized clinically by guttae and increased corneal thickness. At its most severe, it can cause blindness due to persistent corneal edema, superficial vascularization, or scarring. Fuchs dystrophy affects the endothelial cells, which are responsible for maintaining corneal hydration balanced at 78% water. Endothelial cells may be varied in size, polymegathism, or shape, pleomorphism, and contain embedded pigment. Collagen excrescences of Descemet membrane, called guttae, appear early in stage 1, disrupting the endothelium. As enough cells are damaged, the remaining cells cannot keep up with osmotic pressure, resulting in corneal edema in stage 2. Bullous keratopathy is a sequela of chronic corneal edema and a feature of stage 3 disease, causing epithelial defects that can induce pain and increase infection risk. End-stage disease, or stage 4 disease, results from chronic corneal edema and includes fibrotic infiltration of the subendothelial space, which migrates through the cornea, resulting in opacification and peripheral superficial vascularization. Fuchs dystrophy most frequently affects middle-aged people, and it occurs in women about 4 times more often than men. It is rarely seen in patients younger than 30 to 40 years. However, there is an early onset variant caused by a mutation in the collagen 8A2 gene that manifests in the first few decades of life. The inheritance pattern is typically autosomal dominant, although there are also spontaneous mutations. The most prevalent genetic risk factor is the CTG 18.1 trinucleotide repeat expansion in transcription factor 4, TCF4. Environmental risk factors include smoking and low BMI. The classic presentation of Fuchs corneal dystrophy is a female patient in her 40s or 50s, reporting vision changes, glare, or a recurrent foreign body sensation. Corneal edema may be worse in the morning since eyelid closure overnight prevents evaporation, or on a rainy day when the humidity is higher. Patients presenting in later stages may have constant blurry vision or intermittent pain due to epithelial defects. Diagnosis is made clinically with slit lamp examination, which can range from guttae in stage 1, stromal haze and Descemet folds in stage 2, bullous keratopathy in stage 3, and scarring, opacification, and pannus in stage 4. Disease progression can be monitored using pachymetry and specular microscopy. Corneal thickness, as measured by pachymetry, is used to gauge the rate of progression. Specular microscopy visualizes the endothelium and may be used to obtain an endothelial cell count, which decreases as the dystrophy progresses. Initial treatment for Fuchs corneal dystrophy is with hypertonic 5% saline eye drops or ointment, which draws fluid out of the cornea. Activities to increase evaporation, such as pointing the car vents at the face, can be suggested. Lowering intraocular pressure may also improve corneal edema. Carbonic anhydrase inhibitors may decrease endothelial pump function and increase corneal edema. If the condition progresses to the point of bullous keratopathy, or if the glare and loss of visual contrast are too severe to drive at night, corneal surgery can be successful. Endothelial keratoplasty, EK, is generally performed when there is no significant scarring. Common forms of EK include DSEK and DMEK. Full-thickness, penetrating keratoplasty, PK, is utilized when there is significant scarring. Decimetorrhexis without endothelial keratoplasty, Descemet stripping only, DSO, may be considered when the guttae are confined to the central scotoma and is currently under clinical investigation. Surgical treatments have good success rates and prognosis is typically excellent. Non-surgical treatments for advanced stages include pain control options such as bandage contact lenses, amniotic membrane transplant, or a conjunctival flap. Cataract surgery in patients with Fuchs corneal dystrophy is a common occurrence that requires some special considerations, as these patients may have corneal decompensation after cataract surgery. Those patients undergoing combination EK and cataract surgery should anticipate a hyperopic shift in the IOL calculations with Descemet stripping automated endothelial keratoplasty, DSEK, compared to Descemet membrane endothelial keratoplasty, DMEK. Combined keratoplasty and cataract surgery should be considered in patients with Fuchs corneal dystrophy with corneal edema, significantly thicker corneas in the morning, or if patients report blurred vision in the morning. In summary, Fuchs endothelial corneal dystrophy is one of the most common corneal dystrophies. The disease typically affects middle-aged women and is associated with autosomal dominant or sporadic inheritance. In Fuchs dystrophy, endothelial dysfunction causes disruption in the hydration balance of the cornea. Corneal guttae, followed by stromal edema, bullous keratopathy, scarring, and pannus describe the stages of the disease. Diagnosis is clinical, and the progression of Fuchs dystrophy can be monitored with pachymetry and specular microscopy. Early treatment is with hypertonic saline. Corneal transplant may ultimately be necessary. Thanks for watching. If you found this review useful, please like this video and subscribe for more content. If you'd like to see more reviews like this, consider becoming a Patreon supporter. Until next time, happy studying!